different technical failures that you would enverse in these cases. Normally, these conversions of unis to total knees is not a very hard scenario, and the issues you get is how to counter the bone loss, how to restore the joint line, and how to control the femoral rotation. These are three basic things to be done or to kept in mind. There are different kinds of case scenarios that one can enter into. Both components well fixed, no progression of other compartment or PFJ acceptable design. In those cases, only go and change the insert. Not very, very common scenario. Equally at the same time, when you have loosening or failure of one compartment, other compartments are okay, PFJ is okay. In those cases, you can convert one component of a uni to another uni component. But for majority of the cases, they would require a conversion to a total knee, primary or the revision component, depending on different case scenarios. I think you had a total full day session yesterday on the failure modes of uni. So the failure modes are going to be on basically malalignment in mobile bearings, the dislocation of unis, not a very uncommon scenario, aseptic loosening, progression to other compartments, polywear, and infection. Talking of pictures like this where you have malalignment of the femur or the tibial component, in those cases, you have no choice than to move back in, take out these components, and do a total knee revision. These are scenarios where you, in an Oxford uni, I've done, I think, a decent number of these, a dislocated mobile bearing poly. Lying in the patellar gutters on the side or on the suprapatellar pouch. So very commonly misdiagnosed because you have to look at these markers that I've shown you, the opaque lines. Otherwise, you don't get to know what is the problem, why is the patient so unhappy. And X-rays normally would give you other points. Progression to other parts is extremely important. And I've seen this pressure, Hemant would second me in this thing. While people were suggesting a huge number of unis to be bunched across for almost every user, your PFJ involvement up to grade 4 doesn't make a difference. This was the point where we were overextending the indications, and we were finding that we do a uni, but there's a progression to the other compartments, the lateral side or the PFJ. And these are the scenarios to be addressed. I would say a compromised indication. It can also happen, which is time-bound activity levels, say 10 years down the line, and you have now involvement of other compartments. Aseptic loosening, normally a scenario with the younger patients, thick polys, uh, uh, undercorrected, like still left in more than 5 degrees of varus, or many times increased posterior slope. The literature says that high amount of this aseptic loosening was there in fixed unis as compared to mobile unis, but I mean, we personally don't feel the same. Infection can happen in any arthroplasty. You have to do an open debridement, antibiotics, and in a couple of cases where infection is paramount, and you have loss of cartilage, and those cases would warrant in for a two-stage revision to a total knee. So we have these kind of sinuses and things going in. Never put in these kind of spacers across in a uni. You'll have a lot of fibrosis to move through. So you have to go in for a standard articulating spacers, if not a standard uh, total spacer. Tibial plateau fractures, not an uncommon scenario because what you get is a small size females, size 2 or lesser. We have patients who are osteopenic, osteoporotic. Early or post-op, there was a hard hammering. We do not have reciprocating saws. We use lateral saws for those cuts or deep impaction. So this is a very important message not to have this complication because this costs you a lot. So avoid deep saw cuts, vertical cut by the apex of spine, use the reciprocal saws. And also people come back with unexplained pain. You have to investigate. There can be other sources like a spine, as you do for total knee. Bone scan is not very helpful. A caveat is do not revise if the course is not known. I've seen many times people complaining of uni and then let's go it for total knee, you will get a relief. If you don't know the indication, you don't know the cause, please don't jump over to a revision of those cases. Treat conservatively, normally in a year or so, they settle down, you consider rest, you consider injections in those cases. When you're going to revise these in the tibia becomes the foray in these scenarios. What you do, you can go in for extratibial cut, you are going to lateralize the tibial component. If it is a small defect, you can plug in the cement over there. You can also move in for metal wedges and bone grafts. Very rare cases ever we require tumor process or rotating hinge. A normal cut taken initially is 6 to 8 millimeters, you go back a millimeter bore, don't go to the base or the bed. 8 to 10 mm resection from the lateral side is good enough. Do not go to the base of the defect. The remnant cement is taken out with a burr. Once you start taking with osteotome, you have a huge chances of fracturing the tibia. And defect has to be augmented. So the lesson here is avoid over-resecting the tibia. What you get normally is a contained defect. And managing a contained defect is not a problem with a cement or a bone graft. You can do it. So contained tibial defect like this, you can always use the Morsley's graft from the remaining part of the femur, pack it up, and you can go with a normal TKR as planned. If it is a bigger defect, you can reconstruct with the bone graft as we do in with for a TKR bone loss augmentation. A bigger defects like this, you can put in the screws across. In cases where you have couple of millimeters as a bone defect, the patient comes in late after uni, there is a subsidence of the tibia going through, you have osteolysis. In those cases, step or hemi-wedge augmentation, these kind of wedges might be required. But whenever using a wedge, please use a stem extender to bypass the defect. Any defect less than 5 millimeter or less than 25% of the medial tibial plateau, you can just put in bone cement. So the management remains very simple on a bone defect on the tibia. Less than 5 mm cement, 5 to 10 metal augments. If it is more than 10 mm, a huge amount of a defect, in those cases, as Dr. Vinal showed you, Esrom Noyles using a sleeve or a cone can be required in those particular cases. Femur, the trick is very simple. Do not take out the implant, let the implant be there. You set in your distal femoral resection. That's the same way. Very simple walkover. Just don't take out the implant and complicate your surgeries. Implant in situ. Femoral rotation is the key because you already have a femoral defect. So you have to use not the posterior condylar axis, but the transopic condylar axis as well as a Whiteside's line as one of the markers to set your rotation. Preferably use interior referencing because that is totally intact in these cases. Augment your defects. Use a CR or a PS how you require through. So femoral rotation, you have a defect like this. Obviously, you can't use the posterior condylar axis, one of the landmarks. You use these two lines and just a simple veil through. So a failed uni case, picture like this with a tibial subsidence, you see excessive amount of varus going on, collapse happening. In these cases, you see a subsidence and now malposition of these components. The poly was already spinned out and lying in the gutter. Removed all three components, taken off. The same way as I told you, the proximal tibial resection just to the base of the defect. Femur one taken off. This is a contained defect which can be bone grafted. Just using a tibial extender and a primary CR knee, you can circumvent these scenarios. So normally, you don't even require a PS for these scenarios. A simple case like this can be handled up. In a literature, obviously, conversion of uni to total knee is associated with poor clinical outcomes as compared to primary. But definitely, UK to TKR is better than conversion of H2 to TKR or a TKR to a revision TKR. So the take-home message is right kind of a decision. You should know what is the problem that is happening to the patient, only then go and revise. Using what implant is not important. Optimize the flexion extension gap. Contain your bone loss with good soft tissue envelope. Keel options available. You might require from a CS to a CR to a PS. You might require tibial or the femoral extension rods. Depending on what kind of inventory you're using, be prepared with the backups. Do not do it in unexplained pain scenarios, and outcomes will be better than a conversion of HTOs or this. Just a last, my message on how I feel about these conversions. So done today by experts, UKs have a very good outcome provided you choose your indications very well. Do not overextend your indications. I personally feel, this is my personal opinion, especially in another part of India, Mrinal would back me up, PFJ is a huge issue. I would never do it in a patient who has involvement of PFJ because they're always unhappy. They want deep squatting, they want those actions and they're unhappy. In those scenarios, please go in for a primary TKR than a UK. But if you choose your indication well, if a high volume surgeon is there, the results with UK will be as good as TK surgeons. But if your experience is limited, please put your hand on a total knee than a uni and give out more complications or compromise your endpoint. So thank you so much for the organizers for a best way, and I've put up what we say across as the best wishes. We always say, chak de phate.